Good afternoon, everyone. Thank you for joining us. If you wouldn't mind just waiting a few more minutes, we're waiting on a few more registrants to join us before we get started. Thank you. Good afternoon, everyone. Thank you for joining us for our special continuing education opportunity today provided by Baco Diagnostics. During today's webinar, you may ask questions at any time by entering them on the question box along the right side of your screen. Questions will be answered at the end of the presentation. Today's webinar presentation is on small fiber peripheral neuropathy diagnosis and treatment with speaker Dr. Lily Kavari. Dr. Kavari is a board-certified, surgically trained foot and ankle specialist in private practice in Dallas, Texas. She has a special interest in diabetic foot care and reconstruction, minimally invasive surgery, innovative medicine, wound care, and sports medicine. She completed her Bachelor's of Science degree in biology with honors at the University of Texas in Dallas. She then attended the Barry University School of Podiatric Medicine in Miami, Florida. She completed 3 years of surgical training in foot and ankle surgery, where she served as chief resident at the prestigious Kern Residency Training Program at the Michigan Surgical Hospital in Warren, Michigan. Her training encompassed all aspects of podiatry, including pediatric foot care, wound prevention and wound care, diabetic limb salvage, surgical as well as non-surgical treatment of the foot and ankle conditions, sports medicine, trauma management, and reconstruction of complex foot and ankle deformities. Again, thank you for your time today, and Dr. Kavari, please go ahead and begin.
Thanks for having me. Thanks for the introduction, Lucy. We'll go ahead and get started. So we're going to talk about peripheral neuropathy, when we should be diagnosing it and how we should be diagnosing for it, as well as some treatment options once we have done our testing and our proper diagnosing of the disease. All right. So as a disclosure, I am a clinical consultant and speaker for Baco Diagnostics, and Lucy did a great introduction, thank you. So some key topics today: what is small fiber neuropathy, and when we should be testing for it, as well as what is epidermal nerve fiber testing. We want to talk about what are the advantages of doing this test and how to perform the test, as well as once we have the results and knowing various treatment options. We will cover some case studies and why you really should be performing this test in your practice, how it can benefit you as the practitioner, and how it can benefit your patients. So just a little background over peripheral neuropathy. Of course, it is an expanding public health problem, especially with the diabetic population increasing. As we all know, of course, there's other etiologies and reasons why people can get neuropathy. However, it really is an expanding problem. It's seen in nearly 40 million individuals in the US. Despite extensive diagnostic evaluation, 50% of small fiber neuropathy is given a diagnosis of idiopathic. So, and we'll go over some other etiologies that could be background for this type of a disease, but a lot of people do get an idiopathic diagnosis, and there's usually not much treatment options available for them other than, you know, opioid type medications. So we want to try to kind of change the course of that. The disease can be due to many underlying etiologies. Regardless of the etiology, the pain is a common factor. It's a very uncomfortable disease to have, and it is often problematic feature of small fiber neuropathies. Of course, we can have large fiber neuropathy, and that's a lot easier diagnosed usually. However, with small fiber neuropathy, that's where a lot of diagnosis is lacking, and that's really in our hands as podiatrists to be diagnosing and testing for this disease. Once we have our diagnosis and testing is done, the therapy is tailored towards the identification of how bad the disease is, the severity of the disease, and the treatment of the neuropathy when possible, while simultaneously we're matching the pain. So we want to know why they have neuropathy. We want to test for it and really see how bad the neuropathy is. And of course, treat the underlying disease, but also manage the symptoms of pain that the patients are having. So what is small fiber neuropathy? Small nerve fibers relay sensory information. So that includes our pain, temperature, in particular. Initially, they can start as purely autonomic symptoms, which is what we also see in large fibers. So it's really hard to distinguish between the two initially. But when the patient presents with that pain and temperature type of symptoms where, you know, they're experiencing burning or experiencing pins and needles in the toes, a lot of times you can contribute that to small nerve fiber, and that's how we can distinguish it from the large fiber nerves. Small fiber neuropathy usually occurs when damage is mostly to the peripheral nerves, and it is affecting our myelinated as well as unmyelinated fibers. So because of that, it is length dependent. So what's affected at the earliest stages and what's affected most severely are the nerves located most distally. So, you know, balls of the feet, the toes, fingers and hands, palms of the hands. So it does have that glove-like distribution when it is more advanced. But again, aside from that pain and temperature symptom, when the patient describes it as a symmetrical pain that's in the feet and in the hands, a lot of times that should again direct you towards this being a small fiber neuropathy and not so much large fiber neuropathy. As we mentioned, it is a stocking and glove distribution that the patient is having symptoms in. So a lot of times it's on the plantar aspect of both feet, it's in the palms of both hands, and that should immediately kind of turn on the light bulb in your head that you're dealing with SFN. In rare cases, is it where we see a non-length dependent neuropathy that can involve the proximal aspects of the limbs, the face, and the trunk. But a lot of times, that's where we're thinking about large fiber neuropathy. So that's very rare that it's affected with small fiber neuropathy. The small fiber, just we're looking at that hands and stocking and the glove distribution. Some symptoms of this type of neuropathy, of course, they vary widely, but they can include very vague disturbances of sensation. For example, there feels like there's a wrinkle in my sock, or there's small pebbles or sand in the shoes, which is also very similar to neuroma type symptoms, right, that we get from patients. So when they feel that, or they're just feeling some dullness in the toes, small amounts of pins and needles, burning at night, those are all symptoms of small fiber neuropathy. Most patients will report transient kind of electric shock-like symptoms and pain. It lasts only a few seconds. It's very severe, but it kind of goes away on its own, and it can happen multiple times a day. So this electric shock type symptoms are experiencing throughout the day. And the burning is when they're experiencing it more at night, which is what's keeping them awake. The symptoms do worsen during nighttime and at rest. So again, it's really important to listen to patients' history, patients' kind of clinical exam, of course, but really that medical history and the types of symptoms they're feeling should be what's directing us into thinking, okay, are we thinking and worried about large fiber neuropathy, where we're referring the patient out to have EMG or NCV studies? Or are we purely having small fiber nerve type symptoms reported by the patient where we need to kind of focus on testing for that small fiber neuropathy? So that's really what's going to distinguish what you decide as far as testing and how you're going to proceed with testing for that particular patient. So again, symptoms of small fiber neuropathy, we can have positive symptoms and negative symptoms, as well as autonomic symptoms. Autonomic symptoms are, of course, involving those sweat glands. So a lot of times we can see anhidrosis versus a hyperhidrosis. We see in a lot of our diabetic patients, or really any neuropathy patient, because their sweat glands are not getting that autonomic sensory, they have very dry skin, they have cracked heels, they have fissures. So that can be a symptom of that small fiber neuropathy. They can have negative sensory symptoms, and that's where that numbness kind of complain, the feet feel cold, the feet feel tight and stiff. That comes from that negative, so it's the absence of symptoms, right? So things are feeling numb, things are feeling tight, and feeling cold. Positive symptoms are what the patient is hurting from and kind of experiencing, and that's the pain aspect, the paresthesia. So a lot of burning, prickling, shooting pain. So those are positive symptoms that are reported by the patient, and these are the most common kind of symptoms that we receive and hear about from our patients. So again, important to kind of be on the lookout for these and see how many of the symptoms are the patients reporting. If it's more of that early kind of sensation and setting of small fiber neuropathy, the patients are not going to have many symptoms, whether it be positive, negative, or autonomic. I had a patient this morning, she said she feels this weird shooting pain in her big toes just for a minute or two, and it goes away by itself. And she was trying to contribute a toenail infection, all the things, but just getting some clinical history from her. She has sciatic nerve problems, she is diabetic, and that really kind of led me into, okay, this sounds like small fiber neuropathy, maybe early stages. It's starting from both hallexes. So we got her set up for doing small fiber neuropathy testing. So it's really important to listen to the patient and the kind of symptoms that they're having, and really getting that medical history to be able to incorporate small fiber neuropathy testing in the office, and really start the patient on treatment early so that they're not getting on a routine of getting gabapentin or Lyrica or whatever it may be as far as opioids, because as far as we all know, those are just treating symptoms and they're not actually treating the nerves or preventing progression of the disease. So the earlier we can do this kind of testing for patients and really identify small fiber neuropathy, the more we're doing for that patient, and really kind of helping them preserve that quality of life during their days and nights. So some common causes of small fiber neuropathy. We have, of course, diabetes type 1 and 2. It can be idiopathic. Patients can be pre-diabetic, where they just have terrible kind of altered metabolism and glucose kind of absorption in the body, and of course they can have neuropathy type symptoms. They shouldn't absolutely be a diabetic before they can get symptoms. They can get this very early on in the stage of diabetes. Alcohol abuse, HIV, amyloidosis, they can get it as a secondary side effect to certain medications. if they've had solvent exposure. A lot of times we see it in our chemotherapy patients. So if they're going through chemotherapy or they're post-chemotherapy, they can have quite severe neuropathy. I get a lot of those at the office. We have an oncology center across the street, and so we get a lot of patients referred to us for neuropathy secondary to chemotherapy and radiation. And the thing to know about these patients is that it's very reversible for them. It's not like diabetic patients where you can't really reverse the neuropathy in chemo. If you catch it early on and you start them on treatments, you really can reverse their symptoms and get them back to that healthy stage of nerve health. So again, early diagnosis is very important for patients like that. Other causes can be leprosy, vasculitis, certain autoimmune disorders, as well as celiac disease that can cause small fiber neuropathy. So as far as clinical testing of small fiber neuropathy, it can be very confusing. It can be inconclusive. Of course, we're all using different tools at the office. We're doing pinpricks or Weinstein. We're doing the vibratory device and checking for proprioception. So these are very inconclusive, and the patient's reporting can't really depend on that. It's not an objective test. One of the hallmarks of pure small fiber neuropathy is that they can have normal neurological examination. So you may do your Weinstein and the patient says yes to every aspect of the foot that you're testing. However, they're still having neuropathy type symptoms. So you can't really depend on that clinical testing. It's not very accurate. Coordination, motor, and reflex examinations will be normal because those are all large fiber neuropathy symptoms. So we can't really depend on those. Of course, like we said, light touch, vibratory, and proprioception are what we're looking for. But again, clinically, they can always be normal and present as normal and give a false negative clinical examination. Patients may have decreased pinprick, decreased thermal sensation in the affected region, and they might have mildly reduced vibratory sensation, but again, you can't really depend on those. What we're looking at in the skin are those autonomic symptoms. So again, anhidrosis versus hyperhidrosis. So skin changes can include dry, cracked heels. They can be very shiny skin, which of course can have a vascular component as well. But you're also looking at decreased moisture on the areas where the patient is experiencing symptoms that they're describing. So skin changes you can kind of depend on. However, none of these are going to give you a 100% diagnosis that yes, this is small fiber neuropathy. So history and physical examination, like we talked about, are still the gold standard. Sitting there, listening to your patient, seeing when every symptom started, how they're distributed, what the symptoms are, that really kind of gives you the early thinking of, okay, this is small fiber neuropathy and we may need to test for it. You want a detailed review of the symptoms, the rate of progression, and the complaints that they're having. Is it suggestive autonomic fiber involvement, or is it more of the small fiber neuropathy? Generally, if the patient presents with a history of small fiber neuropathy and the appropriate clinical exam is performed, leading you more into thinking that yes, there's small fiber neuropathy, you do need to do further testing to confirm the diagnosis. But it's very limited that you can depend on that. If they're very, again, compelling story, they're giving you the appropriate symptoms, you have the clinical exam where there's Weinstein sensation that's absent, vibratory sensation is absent, only then can you say, okay, maybe we don't need further testing. So it's just very rare, and it's only likely in the patients who are maybe diabetic, who have been, long-term diabetics, and given their symptoms, given their history, you can say, yes, this is small fiber neuropathy. That's kind of the end of it. But in most patients, And this is the question I always get. At what point do you do this test? Do you do it on all diabetics? No. I want to preserve this for patients who are early diagnosis of diabetes, or they're starting to have symptoms, or they don't have diabetes, but they're having neuropathy type symptoms. Those are the patients that you really want to do appropriate small fiber neuropathy testing to really get that 100% diagnosis. In many cases, the diagnosis is not as clear as diabetics, and so you do need ancillary testing to provide additional guidance in your treatment. So there's many testing options available, and I won't go into detail about all of these because a lot of them are not really used much these days. There's quantitative sensory testing, which is really looking for the integration of the nerves. It's looking for kind of detection of thermal sensation, thermal pain. So this is something that's not very accurate, so it's not used very often. There is pseudomotor axon reflex testing. So it's an electrical current that's sent through the skin, and those active sweat glands are responding to it. So it's kind of like an ionophoresis, but again, not very accurate, so it's not used very frequently. Next option is, of course, our skin or nerve biopsy. This is a widely accepted technique, and it's looking not only at the quality of the nerves, but also the quantity of the nerves. So it's really looking at that health of the nerve, the structural integrity of the nerve fibers. It is a very specific test. It's about 65 to 90% specific, and about 80 to 90% sensitive. So you are getting both sensitivity and specificity accurate testing with that nerve biopsy. And of course, we have EMG and NCV testing, nerve conduction testing. This is a fantastic test. It's a very accurate test. However, it's going to be completely normal for you if it's a large fiber neuropathy. Fiber and the small fiber neuropathy is going to be the problem. So if you have small fiber neuropathy issues and you do a large fiber nerve test on it, you're going to get completely normal results, and you're not going to be able to help that patient. So, and you may have found that on many occasions where you have referred the patient to a neurologist maybe, or somewhere that, or whether you do these in your office, and the EMG and NCV come back completely normal, however the patient's having the symptoms. So it is important to really identify the symptoms, and that way you can provide that appropriate testing for the patient. So to get into that nerve biopsy testing, also known as the epidermal nerve fiber density testing, it is a test that's been widely used since the 1990s, again, to qualify the quality of the nerves, as well as to quantify the nerves, to see how many healthy nerve fibers do we have available to us. It does provide a definitive diagnosis of small fiber peripheral neuropathy, and because it's kind of qualifying the quality of the nerves, it's able to tell you the degree of the severity of the neuropathy. So whether you have borderline, mild, moderate, severe, or you have completely normal, it is able to give you that degree. This is important because once you start treatment, you want to have something that you can base it on. You kind of have a kind of a starting line that, hey, you were at a mild disease level, and if you do a treatment for 6 months and redo the test, you want to see that the mild disease maybe has become borderline or normal. So you have something to kind of compare it to. You have a baseline for the patient. As we mentioned, it is a highly sensitive and specific test for small fiber neuropathy. Again, sensitivity is about 80 to 90%. And as far as specificity, we're close to that 90% range. So you are getting a proper diagnosis that's definitive for the patient. So this is kind of what looks like when once you send that biopsy to pathology for the patient. What we're looking at is this epidermal layer. So these are the layers of the skin. We have that epidermal layer, which is here on the superficial aspect. Of followed by the papillary dermis, and deep in the biopsy would be your reticular dermis. What we're getting at is only the epidermal dermis. So once you do the biopsy, you're not invading these deep layers. You're only getting those superficial nerves that are sitting in the epidermal layer, and that's what causes small fiber neuropathy. So here you can see they're looking at the number of the nerves. So in a biopsy that you send, they want to be able to see about 10 of these nerve endings, and it's important for them to be in a linear and not swollen. These are healthy nerves that we're looking at. So again, we're looking at epidermal layer. So this is not a deep biopsy. You're not creating a wound in the patient that goes into a deep layer of the skin. We're only looking at those epidermal layer nerves. Advantages of performing this test, of course, you're confirming your diagnosis. It is predictive. You know that it's going to be accurate, and you can depend on that. It does provide you, as we mentioned, a baseline against which you can monitor your therapy and if the treatment that you're doing is working for the patient or not. It is a highly specific and very sensitive test to diagnose and assess for small fiber neuropathy. It is an in-office procedure. It takes less than 5 minutes to do per site. Usually you are doing symmetrical testing, bilateral testing. Most patients have symptoms in the bilateral feet, so you do want to do it bilaterally. In a rare case that they may have only a unilateral leg that's having symptoms, then I still talk to the patient about doing it bilaterally because you want to be able to compare the two sides. So I would say 99% of the time I'm doing it bilaterally, unless the patient just does not want to biopsies and they say, I just want to do the one that's hurting. So, but once you explain it to them and the reasoning behind why you're doing it bilaterally, it makes sense to them and they understand it and allow you to perform it. So as we mentioned, it takes less than 5 minutes to do per site. Very easy to do for you as the physician, and it's very comfortable for the patient. You are numbing that local area, but they're able to return to work or return to their workout that night. They have no downtime, they have no limitation. They can return to their daily activity. If it is a patient that's maybe on a blood thinner, I do tell them to try to elevate their foot for most part of the day, and I do put a little bit of a thicker dressing on the biopsy site, but other than that, they really have no other limitations. It's a test that's covered by both Medicare and private insurances, and it's your same biopsy or CPT code that you would use for a skin biopsy. So it would be your 11104 for maybe the right leg and 11105 for the left. So you do want to build both of those CPT codes with a 59 modifier if you are doing bilateral testing. So again, as long as you have proper documentation of why this patient needs the ENFT testing in your care plan, you will not have a problem with it getting denied. Pretty much all insurances do cover this testing. Again, it depends on your documentation and telling in your care plan, the history of the symptoms and why you're doing the testing, which is to allow for diagnosis of the disease and to start treatment to prevent opioid use, long-term opioid use. So as long as you have those words in there, you will have no problem getting it covered. Of course, you want to look at your state rules and everything, but I've never had one that's been denied or had a problem with it. So the best site to perform the biopsy is by far the most studied one, and it's about 10 centimeters above the lateral malleolus. So you want to identify the lateral malleolus. You want to measure 10 centimeters proximal to the lateral malleolus, and that's the site that you will mark to perform your punch biopsy. Here's a quick video of how I do it at the office. So here you can see I've identified the lateral malleolus and I'm measuring 10 centimeters above it. I do like to mark about a centimeter kind of peripheral circular line around it. You don't want to inject at your biopsy site because you're going to get a negative result. If you're putting lidocaine right where you're doing the biopsy, that's going to desensitize all the nerves and you're not going to be able to get a proper result. So it's important to draw that line about a centimeter, again, at the periphery of your biopsy site, and you're going to inject just proximal to it. So, of course, you're going to kind of wipe the area with an alcohol pad. And then usually I like to use lidocaine with epi to control bleeding. This is proximal enough where you're not worried about, circulation and causing any kind of vasoconstriction. You want to insert the needle beveled up, again, about a centimeter proximal to the biopsy site. And I like to go in that kind of reverse V pattern with the apex proximally so that, again, you're not injecting any of your lidocaine into your biopsy site. So you inject it, usually takes about 1 to 2 cc's. And while you're cleansing the area with some betadine, the area will be numb to where you can biopsy it right away. You don't have to wait like you would for, let's say, like an ingrown surgery. So you wipe the area with some betadine to disinfect, grab the biopsy that's in your biopsy or nerve biopsy kit. No matter what company you use, they're going to have their own biopsy kit. Usually a small 2 millimeter biopsy is adequate. You can see I'm not pushing the biopsy deep into the skin. You just kind of hold it between your index finger and your thumb, and you're rotating it left and right and allowing the punch to do the cutting, and you're not really putting any pressure on it. You can see it kind of lifts it up. Here it's important to pay attention and see that I'm using the pickups and grabbing the biopsy underneath that epidermal layer. If you grab it at the epidermal layer, then you're squishing all of those nerves. And again, you're not going to have a very accurate result. That's going to give you inaccurate results, perhaps give you no nerves, kind of like if you inject the site with lidocaine. So it's very important to preserve the biopsy and grab it from underneath the epidermal layer. That way you're not causing any kind of trauma to those nerves that you have just biopsied. If it doesn't pull out by itself, you can use a small iris scissor to kind of cut it. It does go in a small fixative that's sent to you, again, from your lab. Some need to be rinsed, some don't. As far as dressing after, I like to put some lumicaine at the biopsy site, again, to control bleeding. I put some Sylvadene cream, a little bit of a 2x2, maybe 2 or 3 2x2 gauzes to provide some padding, and some Coban. I let them sit in the seat for about 2 to 3 minutes, and then let them down and they can go back home. I tell them to take the dressing off the next day, and they can just put Neosporin or a triple antibiotic and a Band-Aid on it, and that's it. You don't have to put any sutures or anything like that because it's a very superficial biopsy. Again, it's only limited to the epidermal layer, and you are, it's only a 2 millimeter biopsy. Those sutures are not needed, and we're testing that. Oops, sorry. So how are results determined? Once you get this biopsy and you send it in the proper fixative, what they're looking for is the small nerve fibers. So this is used using an antibody that's going to stain the nerve. It's a protein called PGP 9.5, and that's what's going to stain the nerves and show the integrity of the nerve. So patients with small fiber neuropathy will show a reduced number of nerves. If you remember, I said we want to see about 10 nerve endings in that biopsy, and depending on how many they have is what's going to determine the severity of the disease. But we're also looking for the quality of those nerves. So if you're seeing any axonal swelling, then that's a cause for the disease and indicative of the neuropathy. So if you remember a couple of slides ago, I showed you a slide of healthy nerves and how they were very linear and straight. If you look in here, you can see that swelling and that axon of the nerve, and that shows you that this is not a healthy nerve and can cause small fiber neuropathy type symptoms. As far as the fixative, like I said, me or my medical assistant, neither one of us like to rinse the nerve in and out of a fixative. Just, accidents can happen. So what I like to do at the office is schedule these patients in the morning, first thing in the morning, and we do the biopsy. Takes about 10 minutes max to do for the whole appointment. 10 to 15 minutes the patient is here. Once you're done, you put it in the fixative, and we call FedEx. They're here before noon, and we ship it the same day. So that it gets to the lab within the same day. And thankfully, we haven't had any problems with that. So that will preserve you. That way you don't have to rinse it. Some labs require you to rinse it. Some labs have longer term fixative where you don't have to do any rinsing. And so you do want to talk to your lab and really see what type of kind of protocols they have in order to be able to get the proper results for the test that you're doing. So once you have the results, comes the treatment options. Of course, the treatment, the first and most important one is to treat the underlying disease. So no matter the etiology, you do want to, of course, have that controlled and treat it. And then you want to select treatment based on evidence of safety, efficacy for that neuropathy condition. Are we worried about drug interactions? What are the patient's comorbid conditions? And of course, everybody's concerned about cost. So there's several different classes of medications that are commonly used to treat the pain. Again, we don't want to focus just on treating pain and symptoms. We want to also focus on preserving the nerves from and preventing the neuropathy from progressively worsening, but also we want to actually help those nerves get healthier. We're not going to be able to reverse the disease, however, unless it's a chemo patient like we discussed earlier, but we do want to really work on the health of the nerves as well as treating the symptoms. So some treatment options. Of course, if it's a diabetic, blood sugar level management is very important. Diet and lifestyle modifications. Certain vitamins that are important for nerve health include alpha-lipoic acid, benfotiamine, vitamin B6, B12. There are topical medications such as lidocaine patches, lidocaine gel, topical pain creams that maybe are compounded and include things like ketamine, of course, that you can use, CBD cream if you have that at the office. They can be helpful for the patient. In severe cases, if they're having severe symptoms, then you're thinking about opioid management. So tramadol and other opioids are like gabapentin and Lyrica, but of course those should be your last lines of treatment. There are non-pharmacological options that are also available. There are certain types of socks that you can recommend to the patients, things like foot tents that are available. You can use electrical nerve stimulation units, such as TENS units, Zynex, that has, I don't know if you're familiar with it, that has like something called the IFS, which is really causing that frequency in the tissue, and it works a little bit better than that TENS unit. Things like acupuncture, physical therapy, nerve massage, laser, if you have an NLS laser or any other kind of laser that's available to you at the office, those all help with neuropathy. We have an NLS laser at the office, and we follow their protocol, and it helps a lot with patients as far as the tightness that they feel, the burning that they feel in the foot, and kind of that spatial. So we had a patient that couldn't feel when she was pressing on the brake versus when she was pressing on the gas. So that's something that, you know, we did vitamin management, topicals, but we also did laser on just to help her with those. So you can really kind of get creative with this and really, you know, alter it for each patient based on what they need and what their lifestyle is. So, but there's lots of treatment options out there. The most important thing is really diagnosing the problem and knowing 100% for sure that you're dealing with small fiber neuropathy, and then kind of leading your treatment and starting your treatment based on that diagnosis. So like we talked about, there's dietary supplements, whether the patients get these over the counter or you have a supplement that you sell at the office. These are important vitamins to suggest to the patient, and these are ones they should be on a daily basis to really preserve that nerve health. So alpha-lipoic acid, benfotiamine, vitamin B6, vitamin B12, and a daily folic acid. This, of course, plays a role in improving the repair of the nerve injury because it's proliferating and migrating Schwann cells into the area. So you're actually getting nerve growth factor. So you're really helping to grow new nerves and really reducing symptoms. So having a patient, and I think it's important when they get their diabetic diagnosis for their PCP, or if they're coming to you for their first appointment, to get them on a daily folic acid. Even if they're not having any kind of neuropathy symptoms, you're really preserving their nerves and helping them prevent peripheral neuropathy. So a daily folic acid is a fantastic suggestion that you can have for your patients. But if they are having symptoms, those are other vitamins that they should be taking on a daily basis for their optimal nerve health. So if you have a supplement at the office, usually most are 1 tablet twice daily that are physician dispensed. However, like I said, these are all over the counter, and if the patient does not want to get it at your office, they can be obtained at local stores. So here's our first case study. This is a 63-year-old Caucasian male. He presented with worsening numbness, tingling, and burning in both feet. He graded the pain level at a 10 out of 10. He is currently taking gabapentin 100 milligrams twice daily, which he says is not helping. His pain has been worsening over the past 6 months. Since he had his back surgery, pain is worse at nighttime. He did have an NCD and EMG study that was ordered through his primary care. However, it did not show any significant damage to the large nerve fibers. His medical history included diabetes type 2, back problems, hypertension, and high cholesterol, and he did not drink or smoke and use any illicit drugs. So we performed the ENFT testing in the office. There were no complications with that. The results that we had were 2.5 fibers on the right calf and 4.0 fibers on the left. So of course, like we said, we want to see about 10, but for normal values, we want them to be 7 fibers or more in each millimeter of the biopsy that we're sending. So the less that we have, the more severe of the disease. Here you can see on the right side, he had 2.5, so it's a pretty moderate neuropathy. On the left, he had 4, so he had mild neuropathy. So we started him on those vitamin regimen. We have the supplements at the office, so we started him on that, and he was taking 1 tablet twice a day for 90 days. I followed him up usually at the 3 months period. If they come back in 3-4 weeks, they're going to tell you nothing has changed, because it's going to take time for those vitamins to show some relief and some effect. So usually I do a 3-month follow-up with the patient. At this point, he reported improvement. He reported that he could finally sleep at night, and he did have some occasional discomfort throughout the day. So I did prescribe him some Lyrica that he would take on an as-needed basis, just PRN, but continue with the daily supplements and the folic acid. He revisited us at 6 months and reported continued improvement. So we didn't really need any additional treatment for him because, again, he had mild to moderate neuropathy. So really the daily supplements and the occasional Lyrica is what he needed. Most of us don't get those vitamins in our diet. So it is important to take him as a supplement to really provide nerve health and improve nerve health. Our second patient is a 51-year-old Middle Eastern female. She presented with tingling, burning, and feeling of heaviness in her bilateral legs. Her pain level was at about an 8 out of 10, and it was worsening over the past 8 months since she had a kidney transplant. Her pain was worse at nights, and it was worsening over time. And she hadn't seen or sought help or treatment for this before us. Her medical history included Sjogren's syndrome, hypertension, high cholesterol, of course, the kidney transplant, and hypothyroidism. And again, she denied any smoking or drinking or illicit drugs. So again, we performed the ENFT test at the office. On the right side, we had 4.1 fibers. So that was early evolving, kind of mild disease. However, on the left, we only had 0.3 fibers. So that showed us advanced and severe neuropathy. We started her on the dietary supplements for 90 days. I believe I also sent her again Lyrica for her pain. At the 2-month follow-up, I'm sorry, actually I take that back. She did not want to take any pain medication, so we only did the dietary supplement twice daily for 90 days. At her follow-up, patient reported improvement in symptoms. She came a little bit earlier than our normal 3-month follow-up because she was still experiencing some heaviness in the right leg. She was still having some tingling and burning, and she was kind of unhappy with that. So we kept her on the vitamins. However, we also started her on MLS laser treatments, and the neuropathy protocol was used. Basically, you're doing the laser at the root of the peripheral at the nerve right by the fibular head. You're also doing it at the PT level and the sural level behind the calf. So that you should have the neuropathy protocol if you have the laser machine. So we did that laser treatment for the patient. She still continued dietary supplements. She did well with the laser treatments. With laser treatments, they do have to maintain it. So usually about every 8 weeks, they're getting 1 additional treatment to kind of maintain it. And of course, the dietary supplement. She had great clinical improvement, so we didn't do any further testing for her. This is kind of a sample report that you see from the lab. It is separated to right and left, and it does show you the number of the fibers that the patient has on each side, and if it's a mild or you're having more of that severe disease. It does mention in here, the vitamins that are important for the patient. So here we have alpha lipoic acid and thiamine. Of course, there's other ones down here like B12, but B6 is also. So it's good to have this report and show it to the patient and discuss it with the patient. That way they really see their biopsy results. They see why they're taking these supplements. It's not something you're just trying to sell to them. It's backed by their biopsy results. And if, 6 months later, they still say, well, I'm not sure if I've improved that much, and They want the testing to be redone to see if the supplements are working, or if, you know, the laser worked for them, or anything like that. You can always redo the biopsy and compare it to the original result and see the difference. And maybe the 4.1 has changed to a 5.0. So it is important to have this and really discuss it with the patient. And a lot of times it helps for them to understand what's going on, and it keeps them a lot more compliant with your treatment as well. So here's our case study number 3. It's a 58-year-old Caucasian male with stiffness, pain, burning, and stabbing in the big toe joints. His pain level was rated at a 9 out of 10. His pain was worsening again since he had back surgery about a year ago, and he had a negative nerve conduction study. His pain was worse at nights, worsening over time, and they were in the bilateral feet at the forefoot level. He does have a history of gout, back injury, bunions, as well as reflux disease. He does drink socially, alcohol socially. He works as an airplane mechanic, so he's on his plane, on his feet, 8 to 10 hours a day, and he does not do any smoking or drugs. So again, we did the study on him. We did the nerve testing on him. There were no complications. His tests they kind of surprised me. You can see they're above normal. He had 13 fibers on the right and 12 on the left. However, this is where the quality of the nerves came in handy. So he had a lot of degenerative changes within his nerves. So remember that axonal swelling that we saw on that one slide. So this is it wasn't the quantity of the nerve he had the proper amount of nerve and things that he should have. However, they were very unhealthy nerve. So as far as treatment, we started him with the vitamins, 1 tablet twice daily. Again, because he stood up so much at work, I chose to follow up with him sooner. He had some improvement where he said the stabbing had stopped, but the pain was still present in the ball of the feet after standing for a few hours in the day. It did have some hallux limitus in the bilateral feet, so we gave him which was biomechanical. It had nothing to do with the neuropathy, but we did give him a local injection at the MPJ level. I also prescribed a lidocaine patch for him that he was able to kind of use during the day. So we used that for about 4 months along with the supplements. And I started him initially also on pregabalin, 100 milligrams to be taken at nights. He was improved after 3 months, so we stopped that and he had it for as needed basis. I did make him some custom orthotics with some moldable fabric that could be used throughout the day. And then we're going to follow up with him in a month to see if he needs any further treatment like laser therapy. But he did not need it at that time. So again, this patient had more severe symptoms. He needed his feet all day long. So the treatment was a little bit more aggressive, included the vitamins, it included the injections, it included orthotics, it included lidocaine patch and pregabalin, just to get him started and get it to a place where everything was a lot more controlled. And once we were at that point, one by one, we got rid of the lidocaine patch, then the pregabalin, and then we were only kind of maintaining it by using the vitamins and his custom orthotics throughout the day. So again, you really have to assess each patient and treat each patient differently based on what their needs are and what their daily lifestyle is. But the important thing is to know what the health of their nerve is and where to start them as far as treatments. So this was his results, as you can see. Completely normal, healthy nerves, number of nerves. However, you can see degenerative changes are seen among the nerves on both sides. So here's degenerative. So that's something that you would never be able to tell doing a Sims-Weinstein test on a patient. And he wasn't diabetic, he had no other reason to have neuropathy. So this is where the value of this test really is, and you can really help patients quite a bit. And if you're doing procedures in the office, it's great for the baseline of your office and the income for your office. So I believe this is the last case study. It's a 65-year-old Caucasian female, partial loss of sensation, burning, tingling, and stabbing pain. Graded at 6 out of 10 and worsening since her chemotherapy, which finished a while ago, but the pain has been worsening over the past year. It is worse at night, and the symptoms are present in the forefoot. Her medical history includes breast cancer. She's in remission. She's retired and does not drink or smoke. We did the ENFD testing, and she had moderate disease on both sides with 4 fibers on the right and 3.7 fibers on the left. So again, we started her with the supplements for 90 days. On her follow-up, she had noticed improvement, however, still was experiencing some tingling at nights, which woke her up at nights. So we did start her on a TENS unit that she could use at home. She still continued with the supplements. At her 4-month follow-up, she reported using both, and she was very happy with her results. We didn't need any further management. At her 1-year follow-up, she still uses a TENS unit, however, only as a as needed basis. She doesn't get the supplements from the office anymore because a lot of the times, again, the chemo, you can really reverse those symptoms. So she only takes a vitamin B complex, over the counter, and that tends to, and a daily folic acid. So she gets those over the counter and uses a TENS unit as needed, and she's doing very well, and she's very happy. So again, every patient, different kind of therapy based on what they need and what their symptoms. So in summary, small fiber neuropathy is a very distinct form of peripheral neuropathy. Traditional testing methods are very limited in value when you're trying to assess for the small fiber neuropathy. Epidermal nerve testing can allow for an objective documentation of this small fiber, and you can really get early diagnosis. It can be used to monitor therapy, and it can also be used to predict small fiber neuropathy. So again, when you're looking at the quality of the nerves. It's an easy to perform test, which takes minutes to do at the office and can be done utilizing a local anesthetic, and your patient can return back to activity without any limitation. Thank you for being here. Thanks for your attention, and I'll answer any questions if there are any at this time, Lucy.
As of right now, we don't have anything that's come through. Everyone is saying thank you. And I'd like to thank you for your time as well, Dr. Kavari. And to all of the attendees, we will have continuing education transcripts sent out next week. And if anyone has any questions, obviously Dr. Kavari has her information posted, or if you want to send me any questions, I can always forward those to her as well. So thank you all again, and I hope you have a wonderful rest of your afternoon.
Thank you, Lucy.
Thank you. Bye.
Have a good day. Bye.
You too. Bye.